specific biomechanical modeling in the cardiovascular disease. So the CVDs remains to be the leading cause of death and disability worldwide, and atherosclerosis and aneurysm shown below are the two key diseases causing the symptoms and events. And atherosclerosis is characterized by a narrowing of the vessel due to the plaque formation. A plaque typically contains a lipid-rich necrotic core, shown by the yellow stuff here, covered by a fibrous cap. And the fibrous cap is considered to be the only protective structure within the plaque. If that cap ruptures, we then see all the extent of the lipid core going into the bloodstream, forming a thrombus, and then emboli later. And aneurysm is quite the opposite. It is a dilation rather than narrowing of the artery, and it's similar to blowing up a balloon. The bigger the diameter gets, the thinner and weaker the wall becomes, and eventually it is also prone to rupture, cause massive bleeding. Because of the nature of these two diseases, they are both characterized by a change in geometry and morphology. The current management is still largely based on a size criteria, whether either the stenosis more than 70% or a diameter greater than 5.5 centimeters. However, such criteria have been shown to be inadequate in the past. For example, most of the ruptures actually occurs in plaques with only moderate stenosis rather than really large stenosis. And we can actually obtain better stratification just based on conventional anatomical imaging. For example, the CT here would give a very nice visualization of the calcium score. And also MR is a great modality for visualizing the different self-components. We can also incorporate some of the functional imaging, such as inflammation and hypoxia, as well as new vessel formation. And we can also dig into the existing information from anatomical imaging by performing the biomechanics analysis and also texture analysis. So the functional imaging are of particular interest because they can reveal some of the pathological changes, and that helps us to better understand the natural history of the disease and also to better understand the current status as well as some future risks. So here from FDG, F-MISO, and DCEMR, we can see the inflammation, hypoxia, and the new vessel formation respectively. And we're also interested in the biomechanical burden because we know that the arteries are subject to cyclic loading and deloading due to the heartbeat. And more importantly, the rupture itself can be considered as a mechanical event when the stress, when the loading really exceeds the inherent material strength within the tissue. And that's why it can be considered as a derived modality to assess the risk of CVDs. Normally, when studying biomechanics, we use a measure called stress, and that is the internal forces, force between the neighboring particles. Normally, it's divided by the area to give a normalized measure. And there are two types of stresses that are of particular interest in CVDs. The first one will be the wall shear stress. So that is a parallel frictional force given by the blood flow. And the second one will be the structural stress, and if it's in the plaque, it's called PSS. So that will be the actual stress within the solid domain, and that's introduced by the blood pressure. So both of these would have an active role in the initiation, development, as well as the failure of the plaque or the aneurysms. So that is to say we have information from anatomical, functional, and derived imaging modalities, so we can aim for a better understanding of the disease. We can aim for better assessment of the clinical risks and eventually aim for a better clinical practice. So the biomechanical modeling typically starts with a reconstruction of the geometry. So here I'm showing a very old 2D protocol, but we now have 3D imaging protocols as well. But the principle is the same. So we look at a series of in vivo images and then delineate the different components of the lesion. We then have a series of contours which can be stacked together to give a number of isosurfaces. This will then give us a volume which can be further discretized into smaller blocks known as elements. So that's why the simulation is normally called finite element simulations. So we model the solid domain, the plaque itself, or the aneurysm itself, using the Cauchy momentum equation, and the fluid using Navier-Stokes. And for each element, we assign the corresponding material property as a given strain energy density function that are measured and fitted using the real samples obtained either from endarterectomy or postmortem. So with all these building blocks, we can then apply the external loading and fixities, and this leaves us a huge number of partial differential equations. But the best part of the job is that normally a commercial solver would just do it for you. And depending on the complexity of the work, you can either go to the kitchen and have a cup of tea, or even enjoy the day off without really feeling guilty, because there isn't really anything you can help with it. But that is also to say we have a trade-off between accuracy and the speed, ranging from different models such as the 3D fully coupled fluid structure interaction to 2D only, structure-only models. And the choice of model typically depends on the actual scenario as well as the imaging data available. So these are the principles, and here I'm going to show a few studies on the coronary plaques and then aneurysms. So the image on the left is called virtual histology intravascular ultrasound, or VHIVAS, for the ease of pronunciation and also for the sake of time. So that is already coming with pseudo color, where the white block represents calcium, the red part represents the lipid-rich necrotic core, and the greenish stuff would be the fibrous cap. And with this compositional feature, we can have some high-risk descriptor of the plaque, such as a large plaque burden PB, a small luminal area, or simply being a thin cap fibroaceroma or TICFA. So all these features are associated with a high risk of events, but the predicted power on their own are still relatively low. But something else we can do with this VHIVAS image is that we get all the geometry and different compositions already, so that we can assign different material property to it and calculate the mechanical stress. So that's what we did in a previous study. And what we found is that by combining the VHIVAS together with mechanical stress, we can aim for a better stratification of the plaques. So in this figure, plaque A and B, they both belong to the type of thin cap fibroaceroma. And if we look at the plaque burden, which is the primary measure for the plaque, showing in the blue curves here, they have more or less similar plaque burden. However, if we also calculate mechanical stress along the vessel, we would then immediately see that plaque A showed a huge inhomogeneity across the length, while plaque B showed a low stress level overall. And in fact, at the end of the study, plaque A suffered from some MACE adverse clinical events, while plaque B didn't. So one of the key rationale of using biomechanics to assess CVD is a hypothesis that rupture itself is mechanical driven, but that really has to be validated somehow using in vivo data. So that's why we went for another analysis using about 4,000 frames from other plaques with and without spontaneous rupture. So in addition to VHIVAS and the derived stress, we also use the grayscale IVAS and OCT to be certain about the presence or absence of surface rupture or erosion. So what we found in the end is that the structural stress in the ruptured group is significantly higher than the non-ruptured groups. And that's quite reassuring, and really it's a big relief to us. And also, the stress is higher in the proximal segments rather than distal, and that also agrees with the clinical observation. What we also see is that if we look at the thin cap fibroaceroma with plaque burden more than 70%, in this subcohort, the stress is associated with an AUC of 0.84 in identifying ruptured cases, which is very good. And so being able to find the plaque right before the rupture is good, but in most cases, it's really too late for the patient. So what we're also interested to see is whether we can project the future plaque progression given the baseline information. So in a joint study with University of Emory, 40 patients underwent the baseline VHF scan, and in about 18 months, they had some follow-up scan. So in many of them, we see a plaque progression characterized by an increase of area, and also in many of the cases, we see an increased calcium, which is shown in white, and lipid-rich necrotic core in red. There are also certain cases where the plaque actually showed regression, which is, I think, more favorable to the patient. But when the baseline data is given, we can already build certain models on the wall shear stress from the fluid domain and structural stress for the solid domain. And what we're really interested to see is whether using these two stress measures, could we predict or give some reasonable prediction about the future progression and involvement of the plaques. So it's very consistent with previous findings. We saw that the low wall shear stress is associated with an increase in plaque area and plaque burden. Such a trend was not observed in the plaque structural stress. However, we found that a higher PSS seemed to favor the growth of necrotic core, but not the fibrous tissue. And this is consistent in both plaques that showed progression or regression. So in progression group, if we look at the red columns, we get more increase of necrotic core, but less increase in fibrous tissue. For the regression group, we get less decrease of necrotic core, but more loss of fibrous tissue. And now if we recall the definition of a vulnerable plaque, that is a plaque with a large lipid-rich necrotic core, but thin fibrous cap. So this is, our finding is somehow suggesting that a higher mechanical stress is really switching the plaque to a more dangerous phenotype. So in other words, it seems that the wall shear stress is more associated with a change in the size of stenosis, while the structural stress in the solid domain is more responsible for a change in vulnerability. So both of these should really be considered if we want to have a more comprehensive assessment or prediction of the plaque development. And for the last part of my talk, I just want to quickly show some studies on the abdominal aortic aneurysms, or AAAs. So the figure on the right is a typical AAA shown on the contrast-enhanced CT. So we see a large dilation of the vessel, and the dilated portion is normally known as a sac of the aneurysm. There are a few slides just above the sac, which still have relatively normal diameter, and that's normally called a shoulder or the neck of an aneurysm. So along the lumen, we also see some gray areas. That is called the intraluminal thrombus, the blood clots, or IOT for short. So that's very typical in the case of aneurysms. And there has been some ongoing debate on the actual function of IOTs. So many people think it's protective because this is quite intuitive actually, because the IOT would separate the arterial wall from blood flow and blood pressure, hence protecting it. But on the other hand, it also separates the wall from the oxygen supply, so there might be some perturbation of integrity and hypoxia. So what we found in one study last year is that there's a dynamic balance between the two, and the net outcome seems to be somehow conditional to the local mechanical environment. So we found a strong interaction term between the stress and IOT in relation with the inflammation. So that if we see a co-localization of thick thrombus shown in A and D, as well as high stress in C and F, we then are more likely to see increased signal of inflammation in the PET imaging. So this interaction term really, I think, is suggesting that when looking at mechanical stress, we should really look it together with some morphological and shape descriptors rather than looking at the values alone. So quite similar to the coronary plaques, the aneurysm may also undergo expansion, and a fast expansion is considered to be associated with high risk. So if we look at the figure A and D, I think most of us will be convinced that the aneurysm underwent some quite dramatic expansion. And this is also very apparent when comparing the the transverse field in E and F. But luckily, at the baseline, we also got some other imaging modalities. For example, the inflammation imaging, FDG PET from panel B, as well as a measure of stress inhomogeneity from panel C. So we can see a lot of variation from purple to red, which showing different level of mechanical stresses. So we also would like to see whether using the modalities from B and C together with some other demographic features, can we predict the growth of the AAAs? So for the PET imaging in B, we normally use the TBR, the tissue to background ratio, to quantify the uptake. So that will be a normalized measure, and it's divided by the uptake in the background. So if the TBR is really close to 1, maybe that is suggesting, it's not really suggesting any evident enhancement. But when we look at the annual growth rate with TBR, we see this kind of Nike-shaped curve in both shoulder and sac. So in the regions where TBR is high, which is more evident in terms of true enhancement, we did see a positive correlation between the FDG signal and also the expansion rate. So that's already encouraging. We then also had a look at the stress inhomogeneity in relationship with annual growth rate. And that's not very good at all. We see basically nothing out of it. But I think here is the time when the prior knowledge comes into play. So we know that when looking at mechanical stress, we shouldn't really be interpreting it alone. We need to study mechanical stress in relation, or at least together, with some morphological features. And in terms of AAA, a good candidate will be the thrombus burden. So if here we have 40 patients in total. If we just arbitrarily divide them into 2 subgroups, about 20 each, according to the local thrombus burden, then we immediately see is that the aneurysms which showed more inhomogeneous stress distribution, there is actually a very good link between the growth rate and also the stress inhomogeneity. So in this particular sub-cohort, so if we see a lot of thrombus in the baseline, then I think the biomechanical stress can be really used as a good indicator about the future expansion. So these are just some very quick showcases of what we've done at the center in the past 1 or 2 years. And I think they're emphasizing the need to combine all the anatomical, functional, and derived imaging modalities together, so that with the help of mathematical and engineering expertise, we can aim for a better understanding, assessment, and management of disease. I think that's the end of my presentation, and thank you.
Thank you very much indeed, Juan. Are there any questions from the audience?
Concerning your simulations,
Yep.
what kind of simulation conditions did you take? I guess it was a steady simulation?
So it's dynamic. So it depends. So normally it's for the coronary study, it's normally a 2D dynamic simulation. And for the some of the carotid studies and annual studies is a fully coupled fluid structure interaction analysis. So they're both dynamic.
And your boundary conditions, how do you define them? Are they fixed over the population, or do you base?
So it's more or less the same type of fixity across all the patients. So for 2D, normally we would constrain some of the X and Y's, so as a 2D fixity. For the 3D, it would be some fixity to avoid penetration, and also some fixity to basically to get rid of the rigid movement. Does that answer your question?
Yeah, your flow, is it also fixed, or
Sorry?
the flow? Is it also
So flow would be the inlet and outlet, or sometimes a inlet velocity and outlet.
But are the measures based on something you measure within the patient, or are they general measures?
So that will not be patient specific. So that's based on a waveform of the general population.
Any other questions for Juan? If not, I'd like to thank Juan once again for a great talk.
Sounds only.